I thank the APNM organizing committee for this kind invitation. I'm sorry that I could not come physically to the beautiful city of Seoul and present this there because of the current COVID pandemic and the travel restriction. But it is my pleasure to talk about pathogenesis of irritable bowel syndrome, even from a far place, that is India. Now, how common is IBS? The Rome Foundation global study has been published in the beginning of this year, which shows that irritable bowel syndrome is common all over the world in the population, and we all know that in clinical practice we see this patient very often. In spite of it being common, the pathogenesis is 8. The understanding of pathogenesis is 8 evolving. The pathogenesis of irritable bowel syndrome basically relates to dysregulation of gut-brain axis. The factors in the brain include stress and psychological factors, and factors in the gut includes visceral hypersensitivity, altered motility, inflammation and permeability alteration, diet, pathogenic infection, altered gut microbiota, local neurohumoral dysregulation, and genetic factors. Now, earlier, IBS was thought to be largely psychogenic. The term functional was often inappropriately interpreted as idiopathic or cryptogenic, and patients were labeled as neurotic, apprehensive, but otherwise healthy individual with an imaginary illness. But in this understanding of this is changing. We now know irritable bowel syndrome relates to several factors. Much of it is in the periphery, such as the food that we eat, the gut microbiota that we have, how these foods are being handled by the host and the microbe present in the gut, how immune system of the individual is responding to the host luminal antigen, and how GI events are sensed by the nervous system. Therefore, we actually published this diagram where we showed that psychological factor may not be the major factor. There would be much to do in the gut itself, such as food intolerance, infection, dysmotility, dysbiosis, and visceral hypersensitivity. All these factors are summarized beautifully in this paper published by Michael Camilleri in Elementary Pharmacology and Therapeutics in 2015. I will elaborate on these in the next few slides. Now, is IBS related to the brain primarily and gut secondarily? No. IBS is related primarily in the gut and the secondarily in the brain maybe. And that's why in the Rome 4, the word functional has been removed and IBS has been considered as altered gut-brain interaction rather than brain-gut interaction. If you look at the studies that related irritable bowel syndrome with psychological factors such as anxiety, depression, and so on, you will realize much of these studies or many of these studies are case control studies. Here I quoted a meta-analysis published in 2016 where a large number of studies were initially screened and subsequently 11 studies were included. Some of these studies were primarily case control studies. What did this study show? What did this study show? These studies showed that patients of irritable bowel syndrome are more often anxious and depressed than the control population. This is not entirely unexpected because they have poor quality of life, they have morbidity, they have suffering, they have work absenteeism and social disability. So therefore, because of these factors, patient may be more anxious, more depressed than the healthy control. But these sort of studies, which are case control studies, may not prove causality. These are association rather than causality. Now here is a study, which is a very important study published in Gut in 2012. And in this study, what the author did is they followed up a large number of patients with functional gastrointestinal disorder over 12 years period who did not have psychological issues initially, but they found these FGID patients in the long term developed psychological issues later. Similarly, they followed up patients who had primarily psychopathological state and they found they developed FGID later, which shows that the interaction is bilateral. Anxiety and depression and other psychological factors may lead to gut abnormality, and the gut abnormality may drive psychological comorbidities later. So therefore, it means that psychological factors are not entirely unimportant. They are important, but they are not the only reason. So what are the gut-derived factors and what is the interaction between the brain and the gut? We all know that visceral hypersensitivity, which is an important pathogenetic factor in irritable bowel syndrome, may be central and may be peripheral. Moreover, even the central factor may increase the sensitivity of the gut. Also, the peripheral factor may increase the psychological comorbidity. For example, a lot of data have come which showed that glucocorticoid and CRH, which are the stress hormone, they are liberated in excess in psychopathological state, and now they altered degree of gut inflammation and gut motility. Also, emotional disturbances lead to cognitive dysfunction. That means primary sensory area, such as post-central gyrus, is the primary area to sense the event in the periphery. Now, what happens is, in some subject, actually, there is recruitment or activation of emotional areas in the brain in response to primary sensory stimulus. So if there is exaggerated emotional reaction or emotional areas stimulation by the peripheral sensory stimulation, this will lead to panic, emotional disturbances, and exaggeration of symptoms. Peripheral factors may differ depending upon whether we are dealing with patient with IBS constipation or we are dealing with patient with IBS diarrhea. For example, patients of IBS constipation are known to have fecal evacuation disorder, slow transit of the colon, and combination of the two. IBS diarrhea patients have lactose or fructose malabsorption, bile acid malabsorption, non-celiac wheat intolerance and FODMAP intolerance, small intestinal bacterial overgrowth and dysbiosis, immune activation, and post-infection etiology. Here is a meta-analysis that we published recently, and also two more meta-analyses have been published, one from Gerald Holman group on small intestinal bacterial overgrowth among patients with irritable bowel syndrome, and this meta-analysis showed that the proportion of patients with irritable bowel syndrome having bacterial overgrowth was higher than the control in most of the studies, and also it showed IBS diarrhea patients more often had small intestinal bacterial overgrowth than IBS constipation and other subtype of IBS. As I told, association may not prove causation. But here is a study that showed that bacterial overgrowth may be causally related. And in fact, Mark Pimentel summarized in American Journal of Gastroenterology that a SIBO theory of IBS fulfills the Koch's postulate. Now, in this study, what we did is we took 80 patients of irritable bowel syndrome. We did jejunal aspirate culture among them for bacterial overgrowth using a double lumen catheter assembly. Then those who had bacterial overgrowth, 15 out of 80 patients were randomized to norfloxacin and placebo. Those who did not have bacterial overgrowth were randomized to norfloxacin and placebo. And in this study, definition of bacterial overgrowth was more than 10 to the power 5 colony forming unit per milliliter bacteria in the jejunal aspirate. We know that this definition is rather not the best definition. Now we know that even 10 to the power 3 colony forming unit per ml bacteria in the jejunal aspirate is also abnormal and is suggestive of small intestinal bacterial overgrowth. So what happened is, out of these 15 patients who were randomized to norfloxacin, 87% improved compared to placebo. And out of 65 patients who were bacterial overgrowth negative, actually 25% improved following norfloxacin compared to none in placebo. When we pulled this, that is all those 40 patients who received norfloxacin, 37.5% responded. This figure is quite similar to the Pimentel target study, where 40% responded to rifaximin. What does it mean? That if we take unselected patient of irritable bowel syndrome, chance of response following antibiotic therapy would be around 37.5%. But we select them according to presence of bacterial overgrowth, chance of response is 87.5%, which support that the idea that bacterial overgrowth is causally related. This study, the concept has been now substantiated or supported by a Chinese study and a recent American study from Mark Pimentel group. In the American study, they use breath test for the diagnosis of bacterial overgrowth, rather lactulose hydrogen breath test for the diagnosis of bacterial overgrowth. Now, what about dysbiosis? Dysbiosis means qualitative change in the bacteria or microbes, typically tested in the feces. And this meta-analysis showed that patients with IBS more often have a qualitative change in the fecal microbiota than healthy control, such as the bacteria they studied include Bacteroid, E. coli, Lactobacillus, and so on. Now, dysbiosis can be associated with exaggerated small bowel inflammation and small bowel permeability alteration. And here is an old study which showed that patients with IBS, including those with post-infection IBS, more often have altered gut permeability than the control population. So patients with IBS have altered gut permeability, particularly those with post-infection IBS. Also, they have inflammatory marker in the feces more often. Now, this is one of our studies in which what we looked at bacterial dysbiosis by real-time PCR in the feces. We looked at TLR expression among their gut, in their gut mucosa, and we looked at various pro-inflammatory cytokine and chemokine such as IL-6, CXCL11, CXCR3, and anti-inflammatory cytokines such as IL-10. And what we found is there is a close interaction between the type of microbe that is present in the gut, the TLR expression, and the cytokine response. That means those who have more of IL-10, that is anti-inflammatory cytokine response, it may be protective against IBS compared to more of pro-inflammatory cytokine and chemokine response, such as that of IL-6, CXCL11, and CXCR3. And in fact, the amount of cytokine and chemokine, such as CXCL11, correlated with type of bacteria present in the gut. Now, we all know that following acute gastroenteritis, people can develop long-term sequelae such as post-infection irritable bowel syndrome. And this is not unique to only invasive bacteria. The earlier studies showed that it occurs primarily with invasive bacteria such as Shigella, but subsequent studies show that it occurs even with viruses. And the recent study that we conducted in Bangladesh showed that even cholera, which is thought to be a non-invasive pathogen, can trigger post-infection irritable bowel syndrome and post-infection dyspepsia. Serotonin is an important neuromodulator or neurotransmitter. And the serotonin plays a major role in pathogenesis of irritable bowel syndrome. We all know of the total body serotonin, 5% is present in the brain and 95% is present in the gut. Now, the serotonin is important in the pathogenesis of IBS. Serotonin is liberated from enterochromaffin cells present in the crypt of liver cones. Beta-adrenergic, cholinergic, muscarinic, nicotinic, and 5-HT3 receptor increases serotonin release, whereas alpha-2 adrenergic, histamine H3, GABA 5-HT4 receptor decreases the release. Now, 5-hydroxytryptamine or serotonin is liberated from the presynaptic nerve ending. It enters into the synaptic cleft where it stimulates the postsynaptic neurons, and this is responsible for increase in the gut sensitivity, increase in the secretion, and muscular contraction. Therefore, excess of serotonin means that there is diarrhea, whereas reduction of the serotonin means there may be constipation. And this serotonin which is liberated in the synaptic cleft is taken back into the presynaptic nerve ending by a protein called SART protein. Now, this SART protein expression determines the availability of the serotonin in synaptic cleft. Therefore, depending upon the polymorphism in the SART protein, some people can have excess serotonergic activity. Some people can have reduced serotonergic activity. Here are some of the studies which showed that the polymorphism in the SART protein is important in the pathogenesis of irritable bowel syndrome, and also it showed that excess of the serotonin is present in the diarrhea predominant IBS particularly, and also post-infection irritable bowel syndrome. Is there a relationship between gut microbiota, serotonin, and IBS? This is a recent study published in 2015, which showed that indigenous bacteria produce metabolite that signal to the colonic enterochromaffin cells. Enterochromaffin cells increase TPH1 expression and 5-HT biosynthesis. Increased 5-HT is secreted luminally and basolaterally, and increased 5-HT uptake by circulating platelet and activation of these occurs after this serotonergic stimulation. And increased stimulation of meningic nervous system occur by serotonin, and therefore there is increased gut motility. What is the relationship between microbes and the serotonin? We all know that constipation-predominant IBS have reduced serotonergic activity. These people have slow colonic transit. Constipation-predominant IBS patients also often have excess of methanogen, and methanogen may be associated with the reduction in the serotonergic activity, because we all know some bacteria alter serotonergic expression. So an initial retrospective study from Mark Pimentel group showed that if somebody used neomycin, rifaximin, or neomycin-rifaximin combination, there was improvement in the chronic constipation among patients who were producing excess of methane. Subsequently, they did a randomized control trial in which that colonic transit was not assessed, and they showed neomycin plus rifaximin was best to reduce the amount of methane in the breath among patients who have methanogen, excess of methanogen and constipation, and there was improvement in the constipation by neomycin and rifaximin. But in this study, transit time was not assessed. Subsequently, we did a randomized controlled trial where we assessed colonic transit time, we assessed constipation and methane production in the breath following rifaximin and placebo, and we found rifaximin was able to reduce methane and able to improve transit and improve constipation. Now, what about bile acid and irritable bowel syndrome? We all know that bile acid is liberated from the liver into the gut. In the ileum, 95 to 96% of the bile acid is reabsorbed, goes to the liver, and then subsequently it comes back again to the gut, and this is called enterohepatic recirculation of bile acid. And this is mediated by FXR, which is present in the ileal epithelial cell, which liberate FGF19, which gives a negative feedback to bile acid production. Now, in the left lower panel, here is a meta-analysis of bile acid malabsorption among patients with IBS diarrhea, and you can see in the most of the studies, or at least some of the studies, there is bile acid malabsorption among patients with IBS-D. Because IBS diarrhea does not have the similar pathogenesis in everybody. In some, it is related to bile acid malabsorption, but not in others. There are several mechanisms of diarrhea in patients with IBS rather than bile acid malabsorption alone. Several studies, including one given here, showed that bile acid binding agent such as cholestyramine, cholecalciferol reduces the fecal bile acid and improve diarrhea in patients with irritable bowel syndrome. Now, obeticholic acid, which is an FXR agonist, and as we told, FXR is stimulated by bile acid. FXR liberates FGF19. FGF19 inhibits further production of bile acid. So therefore, it is expected to improve diarrhea. And here is a study which showed that obeticholic acid, which is an FXR agonist, was able to improve bile acid diarrhea. There is a next talk in which this topic is going to be discussed, that is FODMAP diet and IBS. But briefly, let me touch upon the role of FODMAP in the pathogenesis of IBS. The FODMAP stands for fermentable oligo monosaccharide and polyol. This dietary ingredient, they are not digested, therefore they produce osmotically active substances. They also produce a lot of gas, and this may result into gut inflammation, immune activity, barrier defect, visceral hypersensitivity, and osmotic factor, leading to generation of symptoms in patients with irritable bowel syndrome. Now, is it all to do? Now, also we know that gluten may be important in the pathogenesis of IBS, and people have termed this as non-celiac gluten sensitivity. But I think non-celiac gluten sensitivity is a misnomer. This term is not correct. It should be non-celiac wheat sensitivity, as wheat not only contain gluten, but also contain FODMAPs. Now, this study proved that concept. 34 IBS patients symptomatically controlled after gluten-free diet, and in all of them, celiac disease was appropriately excluded. Now, subsequently, they were rechallenged with gluten, 19 patients, and 15 received placebo, and they found that 68% of those who were rechallenged with gluten, they actually developed symptom of IBS. 40% of those who were rechallenged with placebo, they also developed symptom of IBS. Therefore, it is not the gluten, but maybe some other factor is operating. This has been recently studied, and in this study published in 2018 in Gastroenterology, the author showed fructan rather than gluten induces symptom in patients with self-reported non-celiac wheat sensitivity. Relationship between the different factors such as gut microbiota, metabolome, and dietary antigen contained and dietary substances present in the high FODMAP diet is quite complicated and interrelated. This is proved by this study, which was published by InGut in 2016, in which 18 patients with irritable bowel syndrome were given typical high FODMAP food for 3 weeks, and another 19 patients were given low FODMAP food for 3 weeks. These patients were assessed for IBS symptom severity scoring, metabolome by lactulose hydrogen breath test and mass spectrometry, and microbiota by 16S rRNA gene profile. What the author found is that low FODMAP food resulted in improvement in the IBS symptom, but this was associated with change in the microbiota, change in the metabolome, and also change in the breath gas. And therefore, as one can understand from this, all these factors are quite interrelated. For also bloating, abdominal bloating, and abdominal pain, which are very common symptoms among patients with IBS, are multifactorial in pathogenesis. For example, multiple factors operate to cause abdominal bloating, and even severe form of abdominal bloating may be perceived as abdominal pain. For example, female gender, diaphragmatic lowering, gut dysbiosis, gut dysmotility, visceral hypersensitivity, presence of constipation, CNS factor or CNS hypervigilance, abnormal gas production and distribution, and food sensitivity and mucosal immune activation. So therefore, irritable bowel syndrome is a disorder which results from multiple pathogenic factors, and these factors interact with each other in a very complex way. Though earlier we thought that central factors are the most important factor, but gradually we are realizing, though the central factors may be important, peripheral factors are also of major importance. These factors may interact with each other, and all the contributing factors in the pathogenesis of the disorder may be the target for treatment, which is going to be discussed subsequently in this meeting. Thank you so much.